We have a really, really tremendously important topic to review tonight that I think will be of immense interest to a lot of people that are watching. This should really help alleviate a lot of concerns from people, and at the same time give you some really, really interesting information. This is a really technically sophisticated study done by some amazing people, and it touches on some of those hot button topics everybody likes to talk about, like immune-mediated implantation failures, recurrent implantation failures, and also problems with doing things like the ERA test and Receptiva and so on. So I think we've got a really, really exciting paper to review with you guys tonight. I hope that you all have been safe. Everyone's doing well. Obviously, we're deep into the throes of round 2 of COVID. So hopefully you guys are all staying safe. Your families are safe, and you're weathering the storm. We certainly want to send a huge shout out to all the moms and dads out there already who are struggling through this with kids that you already have in school and all that. I know it's a tough journey for those of you who have children and are struggling, and for those of you who are trying to have children, we're going to get you there. And actually this study kind of helps demonstrate that. So hopefully you'll all catch on to that as we go. And I also want to send a huge shout out to the egg whisperer, Dr. Amy Evazadeh, who interviewed me on the weekend, and on her YouTube channel, you can find us there. Very nice lady from California who does some amazing interview work for fertility. And I think we're going to be having her on our show soon, and go back on her show a little bit back and forth. We seem to have a lot in common and hit it off really well. So some exciting stuff coming up around the corner, and hopefully we can have you all join us there. So I'm just going to let some extra people jump on, hopefully some folks from Instagram and YouTube and so on, and then we'll get started. And the topic tonight is, does recurrent implantation failure really exist? And the reason we decided to ask that was I came across a study. Again, it's in press, which means it's getting ready to be published. And that study basically looked at the rate of true recurrent implantation failure, to say specifically that it's actually quite low. And they looked at doing 3 embryo transfers in a row with euploid embryos. So these are genetically normal embryos, to see how high the success rate would be if you've done it enough times. So very, very cool study. So I'll kind of dive right in there, and then we can start talking about what it all means. So first thing to tell you about this study is this is retrospective. So they looked backwards at data that they already had. And the names in this study are pretty big names. In particular, Dominic de Ziegler is a huge name from Europe in the fertility world, does loads and loads of research and is very well known. And then Richard Scott, who is probably the smartest guy I've ever met, and the operations manager and sort of medical director of IVI RMA worldwide. So Richard Scott is a brilliant, brilliant guy. He's an embryologist who became a fertility specialist. He knows everything about everything and is probably one of the most widely published fertility specialists in the world. So this is a very interesting study. It involved a couple of different locations. They did RMA, New Jersey. They had a hospital in France. They looked at another place in New Jersey and the Yale School of Medicine in New Haven, Connecticut. So some really top-notch locations, some top-notch programs, a lot of effort, and the names involved, like I said, are important because these are people who know their stuff and are not just going to publish junk science. So essentially what they did was they wanted to look at whether or not failures in implantations were related to the embryo or the patient or whatnot. And so they said, let's take a look at the number of patients that sequentially put in a genetically normal embryo and find out what the overall chances were that they conceived, were clinically pregnant and then went on to have a live birth. And they also even looked at miscarriage rates. So this is important data because it's actually not been done like that before. And so when we have a failed embryo transfer, and we especially if it's a euploid embryo where it has been genetically tested, we're all scratching our heads. We start looking for things to check. Is it the immune system? Was it the embryo itself? Was it the patient's uterus? Is there something else going on? How do we know what the specific cause is? How do we know what the problem is? And what do we test for? And what do we, more importantly, for all of you, out there who are going through this, what do we treat you with? So we all are trying to figure out what is going on when we have a failed transfer, especially when it's euploid, because we don't actually know what's wrong. So these guys wanted to answer that question. How many embryo transfers does it take? Or are there some people that just genuinely have recurrent implantation failures? And so what they did was they looked at a pool of patients that had undergone sequential euploid embryo transfer. So in other words, they knew that they had a genetically normal embryo, and they went ahead and they did a frozen embryo transfer. And the whole population was frozen embryo, single embryo transfers. So none of these were fresh. All of the embryo transfers were frozen. So it eliminates that whole guesswork with fresh versus frozen. They wanted to make sure that they had an answer that was uniform amongst everybody, and that way they could compare the groups regardless of which country they were from. So in terms of the study population, it's important to note that the majority of the patients were younger, but they did actually allow anyone from the age of 18 all the way up to 45 years. They had to have a reasonable body mass index, so less than 40 and over 18, and no problems with their uterus or anything like that. It did not include patients with egg donation or gestational carriers or anybody with a major abnormality. And if your uterine lining was less than 7 millimeters after you took estrogen, they excluded you as well. So important thing, these were not women necessarily that had multiple genetically normal embryos from one cycle alone. So if they didn't have remaining or residual normal embryos after one cycle, they actually put them through another cycle and then used the data from that second or even third cycle, and they go into the numbers for that, so I'll explain that to you. All of them did receive the pre-implantation genetic testing. That was done when they reached the blastocyst stage, which is really important, and everybody got it on the 6th day of progesterone exposure after they had at least 7 millimeters of endometrial thickness. So that was the overall sort of protocol for this. The doses that they used were all with an antagonist protocol, anywhere from 150 to 450 units per day. So kind of a mix of everything. And that was basically it. And they adjusted them as they needed to. They used either HCG or a Lupron trigger, but interestingly not both. And they triggered when 3 or more of the follicles were 18 millimeters, which is what everybody should be doing. So that's really important. And when they did a Lupron trigger, they actually did a double Lupron trigger. They would do one trigger, and then 12 hours after the first one, they would do another one. They don't explain why, but that's what they were doing there. Their embryo preparation essentially involved monitoring the thickness of the uterus. They gave them daily estrogen and then progesterone. The progesterone was intramuscular, so these are shots. And on the 6th day of progesterone administration, so you've completed 5 days, they transferred in the embryo on that 6th day, which is standard. That's what we're all doing. And if you had more than one genetically normal embryo, they picked the one that looked the best. Okay, so 4,429 women met the inclusion criteria, and 4,111 of them used embryos from a single cycle, 297 from 2 different cycles, and 21 required a 3rd cycle in order to be included in this data pool. Average age was fairly young. So the average age is 35.4. And as you guys can all probably imagine, that's a bit on the younger side for patients doing fertility treatment. Usually it's more like 37, 38, 39. So these were younger patients, and the BMI was only 25.5 on average, which is very low. So realistically, these are pretty healthy patients with good numbers, good data. If you look at even their AMH value, it was 3 nanograms per mil, which would definitely be on the moderate to kind of higher side. Their day 3 FSH values were 8.7. Most of them had 12 to 13 eggs per retrieval, or at least for the first retrieval. So, fairly good success rates, 10.5 fertilized embryos. And they said that the rate of having a genetically normal embryo was 3.54 from just one cycle. So that's a good responder. These are selected patients who are having a good response. So this does not apply to everybody. And this is the reason these sessions, which I do for everybody out there, are important, because you can read this and say, oh, I just need to do this, but you also have to make sure the study actually applies to you. If the study doesn't apply to you, it doesn't make sense to go ahead and do it, to apply the data to you. So I'm just going to try and share for those of you who are on Facebook and YouTube and so on. And the application window disappeared, my friend Tarek. I have no idea where that went to. There. Okay, it's back. Yeah. Okay, great. Thanks. It wasn't there a minute ago. What we've got. Okay, so here is the data, and I want to kind of blow that up so you can all see it. For my Instagram friends, I'll explain it to you, because we, for some weird reason, social media doesn't love each other, so we can't share with everybody. Okay, so this is the first one, the first graph, which is really important to see. And I can read you out the numbers, but essentially what it shows is, this was when they looked for clinical pregnancy rate, so presence of a heartbeat. And what you need to know from this is, from the very first embryo transfer, they got 69.9% success rate, which is really quite high. So what you need to take away from that is, if you're a reasonably young, healthy patient with a genetically normal embryo, you kind of fit the bill of what they saw in this study, you've got a 70% chance of conceiving if your embryo is genetically normal. From the second embryo transfer, 59.8% of those patients then got pregnant. And then from the third one, 60.3%, right? So all those numbers are relatively close to one another. There's a little rise and fall. But what you need to know about that in total is that essentially when you add it all up together, there is almost 95% of the patients actually getting pregnant after the transfer of 3 euploid embryos. So almost the entire group is going to conceive if you have 3 genetically normal embryos and they're transferred in. And keep in mind, none of these patients were receiving any specific special treatments, no ERA testing, no immune therapies. It was just garden variety IVF with nothing special being done and nothing different being done from cycle to cycle. They just kept doing new cycles and transferring in more embryos. So you're going to get a very, very high success rate. When they calculated the actual odds, yes, they did drop as you went through successive cycles. So it's like 64% after the first cycle, like a 64% chance you would conceive. And then it drops down again a little bit further when you go into your third cycle. But really, it's very, very similar. And there was no statistically significant difference between the second and the third cycle. So try enough times, essentially, and you're going to get some success. And they actually looked to see if there was a difference in the age of the patients succeeding between the first or the second and the third. And they actually showed that age did not determine it at all. That was not one of the statistically significant factors. So if you have a genetically normal embryo and your age is higher, you don't need to be worried. If you can get 3 embryos, you should get that incredibly high rate. So the next part they looked at was, well, does this translate into live birth? And essentially, the results are almost identical. So live birth, which is the gold standard, the holy grail, showed the same thing. So it was 64.8% with the first transfer, 54.4% with the second, and 54.1% with the third. So if you're getting into that kind of live birth data, the important thing here again is when you looked overall at everything, again, they're demonstrating that almost 95% of the patients cumulatively were getting pregnant. In fact, it was 95.2% will have a live birth if they have up to 3 euploid embryo transfers. And this is just something we've never seen before. So essentially, if you have enough genetically normal embryos without doing anything fancy, so no testing, no receptiva, no special test, no nothing, no IVIG or steroids or any other treatments, you're going to get a 95% chance of having a baby, So remember I said that, right? This is not just a, opportunity to conceive. This is an actual chance to have a baby. They even looked at miscarriage rates, and they said after the first cycle, it was 7.2%, 8.8 for the second, and 12.7 when you get to the third. So there is a little bit of a concern that maybe as you have to do this more and more, there may be some issues with some of the embryos, and that's probably why there's that 5%. But it looks like you have a very, very high chance of success. So the thing that's really interesting about this is that the authors say, essentially, based on these results, and again, remember, these are guys like Dominic de Ziegler and Richard Scott, who is really the foremost guy in the infertility world right now. They're saying very clearly, and I quote, our findings challenge the publications claiming various uterine causes for recurrent implantation failure and suggest that it is of uterine origin is not a common entity in women whose uterus appears normal on saline sonography and or hysteroscopy. In other words, if your uterus is normal, the reason that your embryo is not sticking is the embryo. It's not anything about you or your uterus. They actually go on to say that all of the tests that are being done, including things like receptiva, including things like the ERA test, all of the various immune treatments and all that other stuff are not necessarily justified, because even with doing nothing, these guys are getting that 95% success rate just by repeating cycles. So that is very, very important to know. Now, does this account for everybody? No. 4.8% of the patients are not getting pregnant. So those people do need some extra evaluation, treatment, and so on. But for 95% of you, 95.2%, do it enough times and you're going to walk away with a live baby. Why is this super interesting? Because Richard Scott is the director of the parent company to iGenomics, and iGenomics is the company that makes the ERA test. So he himself here is saying that it doesn't even make sense. There is no point in doing it because they didn't use it in this study, and they're still seeing exceptionally good success rates just by trying more times. So this is very, very important because there are millions of people out there spending thousands and thousands of dollars for tests, for treatments, for investigations, and sometimes they have no benefit. And that's the whole reason we set up this show, was to tell you the ERA test proven to be useless. We've gone over that data. You should not waste your money on an ERA test. Many of these other things not proven in many, many patients. Now, if you're in that actual 5%, you've tried multiple times, it's not working, sure. You need to have thorough investigations. You need to have options for treatment, and we don't want to abandon you. You are very, very important, and we need to focus on what's wrong. And if we do enough digging, we probably will find something wrong, and maybe those patients will benefit. But for 95.2% of you, you don't need anything extra done. So does recurrent implantation failure exist? It does, but the rate is extremely low, and realistically what you need to do is have a lot of patients have to just go through that one extra cycle, and then you'll succeed. Now, there's no question that this comes at a cost. So I don't know what the deal is in France. I'm assuming it's socialized over there. I can tell you that programs in the States often, especially I think in New Jersey, they have mandated insurance. So the companies get the IVF companies and the labs, they actually get their revenue source from the actual insurance companies. So you can do 6, 8, 10, whatever number of cycles you need. And certainly 2 or 3 is a no-brainer. It's easy for them to achieve. But bottom line is that if you do IVF enough times, even if you have to pay for it, you're most likely going to be successful, and you're most likely going to get a chance to move forward and end up with a baby, 95.2%. even if your age was all the way up to 45 in this study. So as long as your weight's okay, you're a reasonably healthy patient without doing anything fancy, you've got a very, very good chance. So I hope that'll be very useful to you guys. I was super excited when I read this. Yes, it does mean you might need more IVF cycles, but it doesn't necessarily mean that there's no hope. Try enough times and you will succeed. And yes, that does come at a cost, but that's why we've kept our costs low, to help everybody and let them have enough tries so that they can achieve success when you try enough times. So I know everybody's going to be asking, should we all do Pgt? And the answer to that is no, because there is good data that supports the fact that Pgt does not actually improve your success rates. And remember, knowing that the embryo was normal or not is not what made these cycles successful. They just know that if you end up with the genetically normal embryo going in, you're going to have that very high success rate. Certainly, if you're over the age of 38, there's a difference and it supports it. But if you're a younger patient, you don't need to do it, because you know some of your embryos are genetically normal. And you know that even from the data here. In these young, healthy patients, mean age of 35, reasonable AMHs, reasonable weights, they had 3.54 for the rate, genetically normal embryos. So there's no reason to be paying for Pgta, because you can know ahead of time, if you're a healthy, normal patient, you're going to get a bunch of normal embryos. Why would you pay to find out something you already know? So say it is a fiction that recurrent implantation failure is common. It's a fact that if you do enough IVF cycles and you try hard enough, you will actually get a very good success rate and end up with very, very good results. I definitely want you guys to share this with as many people as you can. Spread the word. Try enough times. There's loads of hope. You should be able to achieve success. So I'm going to take questions. Remember always to subscribe and follow our YouTube channel, where all these videos are replayed afterwards. www.youtube.com/drvictory. And of course, if any of you have questions or concerns after the show, don't hesitate to send them to me and I'll happily go through them. So we've got a whole bunch of questions, and I think you have some that people asked ahead of time as well, right? Yep. So I've got one here. Good evening. Had to transfer 2 embryos on Saturday, and I am feeling kind of morning sickness and yucky feeling. Is this normal? Well, if you're pregnant, it's normal, Ash. So that should be a good thing. Stick with it and don't change anything. Do not change a thing because you don't feel good. You can use Gravol. It's safe. Don't hesitate. Hoping surgery start back soon. So those of you who are wondering, we're moving from 1 day a month to 2. They are trying to rebuild the surgeries, so we are hoping to start doing that sooner. So that is the surgery question. Oh, Kel. Hi, Kel. She's saying hi. We love Kel. With cervical mucus, egg white looking, yuck, sorry. Is there any proof once it appears you're officially on your most fertile day? I try and stay away from Google as much as I can, LOL, or am I leading up to ovulation days? Cervical mucus is useless. Don't bother paying any attention to your cervical mucus. If you want to monitor your ovulation, just use an ovulation predictor kit. It has about a 98% accuracy. It's extremely accurate. It's easy to follow. There's no reason to be checking cervical mucus, so don't bother that at all. One more question. Are there any studies on fertility and ashwagandha? I don't know, because I have no idea what ashwagandha is. Tariq, you got some questions there?
Absolutely.
All right, go ahead and I'll scroll back to the beginning.
When using donor eggs, do you prefer to do a fresh or frozen transfer to gestational carrier?
Yeah, so if you're doing a donor egg cycle, we do aim for a fresh transfer, because the whole reason that we avoid fresh transfers in the majority of people using their own eggs is because their estrogen levels are very high. You don't want really high estrogen levels because it increases risks in the pregnancy. It probably decreases success rates based on everything we know. But if you're the recipient, you're not getting really high estrogen levels, so there's no need to be worried about that, and a fresh embryo transfer is fine, probably even optimal, because the embryo isn't being frozen and then thawed. So we do aim for fresh with our recipients, but it's not mandatory. because we know we'll still get an excellent success rate. So if for any reason you can't coordinate the two at the same time, there's nothing wrong with moving forward with having the patient have their embryo transfer done frozen.
What's your favorite part of your job? Former patient asking.
Favorite part of my job? I love those questions. My favorite part of my job is getting the chance to help people. I mean, there's really nothing cooler than waking up every day and getting to go to work doing something that you love. So I love helping people. I won't lie, I particularly love the surgeries. I'm an expert laparoscopic minimally invasive surgeon, so that's a lot of fun for me. But the bottom line is that it's overall the opportunity to use what I've been given to help people and help them in a really meaningful way. So that's my favorite part of my job.
Should I be added melatonin to my daily vitamin regimen?
Yes, 3 milligrams of melatonin has been proven to improve success rates.
How accurate are gender scans at 14 weeks?
At 14 weeks, probably entirely inaccurate, although one of my techs is firmly convinced she can tell even at 12 weeks. But there's no proof scientifically of that yet. We're actually going to consider doing a study. But realistically, it's probably not very accurate at 14 weeks. 17, 18, that's when you really want to find out what it is.
I got more, don't worry.
All right.
Okay. When would my headaches during pregnancy be a concern?
Well, if your headaches are very persistent, if they're not going away, if they're causing symptoms other than the headache, numbness, tingling, vomiting, loss of balance, loss of speech, that kind of thing, you should go get checked out for sure.
Would you suggest IUI versus IVF for a low AMH 0.33 at 34 years?
If your AMH is low, your best chance is still with IVF, but it does become expensive with a relatively low rate of return. So you need to balance the cost of the IVF against the success rate of the IVF. So if money's not an issue, you should definitely be doing IVF. It's absolutely unequivocal. There's no question about that. You should go right into IVF. But if money is an issue, then I probably would recommend not doing the IVF as long as you're ultimately comfortable with either not succeeding, if that, God forbid, happens, or the need to go to a donor and you're comfortable that way. So, you know, if your resources are really limited, you only have one shot at IVF and you're willing to use a donor, I'd probably recommend, if your AMH is really low, that you try IUI first, save your money for a donor IVF cycle. If money's not an issue, you can try a couple of times either way, go straight to the IVF. That makes a lot more sense. And obviously, if you have religious objections, moral objections, whatever, personal objections, and you don't want to use a donor, I'd still probably try the IUI a couple of times and then jump into the IVF. We did a review probably about 2.5, 3 months ago of one study that showed that even if you waited up to 6 months with diminished ovarian reserve, you still had a very good chance of success. And it was no different during that 6-month period. So use a few months to try the IUI. If it doesn't work, jump into the IVF.
Last pretty early question.
Yeah.
What additional tests or scans must be done for IVF pregnancies?
Oh, that's a great question. What additional tests or scans should be done for IVF pregnancies? So technically none, as long as there's only one baby in there. So you just need the standard treatment, but we watch it pretty carefully. So the garden variety routine stuff is enough. If the doctor notices that the baby is not growing adequately, not based on ultrasound, but just on the measurement of your symphysis fundal height, which is from your pubic bone to the top of the uterus, that's when you start getting worried and you got to do lots of ultrasounds. But aside from that, if your history does not suggest there's anything else you need to do, you don't need to be treated any differently from anyone else. Is that it?
That's it.
From your end? Okay. Kayla, what can I do to help with extreme stuffy nose, sinuses, 18 weeks pregnant, And when I lay down at night, my nose gets stuffy and my sinuses feel stuffed and swollen so much so that I can't sleep. Sorry. So just take Benadryl or any of the antihistamine medications. They're all safe. Any anti-allergy medications, most of them are safe. So you can use all of those. You should be fine. If it's just like seasonal allergies, if you're just persistently congested, I'd probably see your family doc and figure out why. Make sure it's not like a sinusitis or a bronchitis or something. But any of those are safe. You can use most of those types of medications. I'm 34. This is Marianne. Have PCOS and suspected endo. My partner has changed since seeking help. We have decided to wait a little bit before trying. Would the birth control pill be okay to go on for a little bit, or could it hurt my fertility in the long run? Great question, Marianne. Birth control pill doesn't hurt anyone's fertility. It's totally safe. You can go on it. And in fact, if you have PCOS and endo, you should be on birth control pill because you need it to protect you from the side effects of the PCO, and it'll delay or maybe even prevent the endo from getting worse. So absolutely, you should be on birth control pill. Whether it's months or years, it won't make a difference. It's safe. Fourth FET with two non-Pgt embryos, pregnant. There you go. Beta 360, but only raising 50% every 48 hours. Is there a chance it will be okay? There is a chance. It's supposed to be 60%, but I wouldn't count yourself out, especially if it's very early. At the beginning, it does not double. So if you're doing very early testing, it won't double right away. It takes a little bit of time for that to occur. So hang in there and get it rechecked. Don't hesitate with that one. What is the best protocol for an FET with donor embryos? Any protocol is probably okay. So we've done lots of stuff on the value of some adjunct treatments like vitamin D. I haven't shown you guys the study yet, but apparently ferritin levels are important. So that's a measure of your iron. We use letrozole, melatonin. So all of those adjunct kind of treatments can improve your success rate, but otherwise, being on estrogen is very reasonable. You should be. And then there's no question that the progesterone in oil, in addition to the vaginal progesterone, is probably the best way to go. That should be done for 5 days if you have a day 5 embryo, and potentially 6 days if you have a day 6 embryo. And then get a good embryo transfer, obviously ultrasound guided. We do use beta HCG in an HCG wash for patients that have previously had failures. So certainly if you're in a donor embryo situation, that's a reasonable thing to consider. Is it normal for embryos to downgrade after thaw? What is a collapsed embryo and how likely is it to be successful? That's a great question. So some embryos will be downgraded after thaw, but not all. Some actually upgrade, some downgrade. Depends if it's the same embryo, just looking at it, to be honest. And then the second part of that question is, what is a collapsed embryo? So when you have a full blastocyst embryo, there's fluid and then there's the embryo. And it's the shell kind of part of the embryo is expanded with the fluid, and then the embryo is inside. In some instances, the embryo will collapse around the shell will collapse around the embryo, and the embryo itself will become compacted. And that's generally considered not a great sign. It does mean your success rates will be lower, but not zero. It's just lower. So it can still happen. So don't give up. If they tell you your embryo collapsed, it doesn't mean it won't work. It just means it's harder to get it to work. Are there specific factors that would prevent you from transferring 2 embryos rather than 1? Yes, every factor. Or can it be requested by patient to transfer 2? So we've reviewed it on the show before, and I say it all the time. Double embryo transfer is much higher risk of twins. So unless you're older, you should avoid it at all costs, because if you end up with twins, it's automatically a high-risk pregnancy. And while I appreciate the fact that everybody wants their best chance of getting pregnant, the reality is if you get pregnant and deliver 2 babies at 26 weeks, you now have a lifetime of problems with 2 kids that potentially have all sorts of complications: cerebral palsy, blindness, hearing loss, need for immediate surgery, God forbid, even worse, death. So do not go for a double embryo transfer under normal circumstances. Now, if the previous embryologist froze them in pairs, you don't want to waste them. Sure, it's reasonable to do them both at the same time. If your age is older and you haven't done genetic testing, again, totally reasonable. But under normal circumstances, single embryo transfer is the best way to go. And that's the majority of what we do and will be doing moving forward. Would I suggest Pgta? This is for Alexi. Pgta testing more so with male factor infertility. We had a failed transfer earlier this year with an optimal uterus environment and well-graded day 5 blastocyst embryo. We did not test our embryos as we only had 2 make it to blast. Well, Alexi, I would need to know your age, but the reality is that the answer is no. I would not recommend Pgta testing for male factor because that's actually being looked at and it does not contribute to a higher rate of aneuploidy. So it is definitely not beneficial. In fact, I think we reviewed that on the show and I've posted it before on Instagram. There is no benefit to doing Pgta for male factor infertility specifically. So don't bother, you did the right thing. If that's the only problem that you guys have, you do not need to do Pgta. It will not be beneficial. If you only had 2 make it to blast, the question is what's wrong, and that needs to be addressed. And there are ways to improve male sperm. So make sure he's doing all the right things: no smoking, no drinking, no drug use. That stuff is really important. And I know it's tough sometimes to get the partners involved, but you have to engage them with any means necessary, or if the guys are watching, make sure you're doing the right things. Whoops, I did that again. I hate it when this thing, the whole thing kind of flips around. Okay, so what is the next question here? What are good supplements to take if wanting to become pregnant? Melatonin, vitamin D, iron, folic acid, a prenatal vitamin, omega-3 fish oils, coenzyme Q10. Those are the normal ones. Alexi's just answering from her previous question. She's only 30 years old. Alexi, you did the right thing. You do not need to do Pgta. Is there an issue if embryo implants at same uterus spot where I had retained placenta removed? No, not usually. As long as the retained placenta wasn't an increta, accreta, percreta, you should be fine. If it is, you're at a higher risk of that kind of placentation occurring again, and they should be very, very careful with you at delivery. But aside from that, no. What should we do if we can't remember if we took estrase or progesterone suppository dose during pregnancy? So I'm not sure if you mean if you can't remember what you did last time or if you can't remember what you did today. I would skip it if you can't remember if you took it today, unless you're in the 5 days before the embryo transfer, in which case, if it's just vaginal progesterone, take it again. If it's injectable, you could overdo it, so I would not do that. Besides male fertility supplements, what other vitamins do you recommend for male sperm count and motility? So we use the YAD products, but they're all basically the same. There's Pro Fertile, there's Fertile Pro, Ubic, there is Fertile Pro MTL, that's specific for motility. There's Coast Fertility. I mean, there's a million different supplements and agents out there. So those are all good. Most important thing for guys, actually, to be honest, is keep them away from the bad stuff. No smoking, no drinking, no drug use, none, zero. The guys are always like, well, I cut down. That's useless. Don't cut down, cut out. You need to get rid of that stuff or else it won't work. Philip is asking, do some couples actually get pregnant so easily just having sex one time? Yes, they do. As a matter of fact, many couples get pregnant just having sex one time. That's what a lot of 16-year-olds show up in the various clinics for. So yeah, it happens all the time, fortunately or unfortunately, depending on the circumstances. So yeah, it can be easy for some and so difficult for others. Is there an increased risk of heart problems for an IVF baby? If you mean heart disease when they're older, no. Congenital anomalies, yes, in particular if you're using ICSI. The rate goes from 2 to 3%, which is the baseline rate for the general population, to 4 to 5%. And some of those will be heart. So yeah, there is a slight increase in risk, but it's not huge and certainly tolerable. What is the ideal follicle size for a trigger shot? If it is 22.5, is it too big and have low chance for fertilization? No, everybody's different. Keep in mind, normally when your ovulation occurs on your own, it usually is around 23, 24, 25, sometimes even later. If you're doing it for IVF, we want the majority of the follicles to be around 18 to 20. If you're doing it for IUI, more like anywhere from sort of 18 all the way out to 22. So 22.5 would be fine. Do I recommend the flu shot during pregnancy? 100 billion%. No, don't wait till the second trimester. The flu shot's harmless in pregnancy because you're getting the maternal flu shot, which is safe. So you should be doing it all the time. Will my low motility and count be genetic to my future male children? Potentially, yes. So guys with male factor infertility do have a higher tendency of having children with male factor infertility. Good question. Are retrievals available to be done at your clinic in Windsor, or are you just doing transfers at this time? We have passed our inspection. We're just waiting for the letter from the college to tell us we can go ahead, which hopefully will be any time. In fact, as soon as we are done, I'm going to write them to see how long that's going to take. We are hoping by the end of this month, we should be able to start. How often have I seen a single embryo transfer split to 2? 1 in 300. So it's a very, very low incidence of that happening, 0.3%. Suffered an ectopic pregnancy due to my endo and lost my left tube. How hard will it be to conceive with endo and one tube? Endo reduces your chances by about 50%, but one tube should not be a problem. It may delay your fertilization because you may, especially if you have endo and there's damage, it may only pick up from one side. If your endo is significant and you're down to one tube, that's not an unreasonable case to consider doing IVF, but there's certainly nothing wrong with trying on your own. It'll take longer, but it's not going to stop you. Do you do anatomy scans at routine OB appointments in your clinic? No. Nobody does anatomy scans at routine OB appointments in their clinic. You're only allowed by Ontario law to do one anatomy scan and a follow-up if they couldn't get anything from the first one. So we only do the ones that we need to. Can I please open a clinic in Toronto? I have a clinic in Toronto. If you want to see me in Toronto, just call the office and we will arrange to see you in Toronto, Philip. So that's not a problem at all. We have a clinic in Toronto. Should we get NT test and NIPT if we are pregnant with Pgta normal embryos? Yeah, people ask that all the time. So the question is, if you've done Pgta testing, should you go and get the nuchal translucency scan for the back of the neck or do non-invasive prenatal testing, which is where you take maternal blood and look for a genetic abnormality? I mean, they're both harmless tests. There is a little bit of a cost for the NIPT if you're younger than 40 years of age in Ontario. Pgta is not 100%. So if you're worried about the fraction of a percent where there can be an error, yes, go do the test. Do I routinely recommend it? Definitely no. But is it reasonable to do it? It's certainly not unreasonable. So if you want the extra reassurance, go for it. Like I said, it's harmless. Philip, sorry if personal question, but wondering why did you decide to become a fertility doctor? It's so cool doing what I do. I wake up happy. I go to sleep happy every day. Like, it's literally the best job ever. I get paid to help people. I mean, what could be more amazing than that? So it's a very rewarding job. It's very diverse. I get to do surgery. I get to be a radiologist looking at ultrasounds. I get to do a lot of technical procedures. I get to hold people's hands when they're going to sleep. I get to do things other physicians can't, especially with the surgical stuff. And I mean, I get to create life. I get to see kids when they're one cell and then, a sperm and an egg. And then I get to deliver them and hand them to the mom and dad. It's literally the best feeling ever. So it's a super, super cool job. I work hard, but I love it. I love every minute of it. Never had a moment's regret. So it's very, very cool. Hello, good morning, Doc. Well, hello and good morning to you too. My recent hysteroscopy showed some scar tissue buildup and blockage in the opening of left tube. Can the blockage be removed? I'd be surprised if someone was able to tell from a hysteroscopy if there was blockage, but if there genuinely was, you can remove blockage in the tube for sure. You just need to have a radiologist that knows how to do it. And certainly in the uterus you can, so that should be easy. And Philip, you're all full of questions, man. What is the percentage chance of miscarriage with a Pgta normal embryo? It depends on the patient, so that's a tough question. But probably somewhere in the vicinity of around 5 to 10% is normal. But generally speaking, it's pretty low. Jennifer Ann on Facebook. Hi, I usually do the letrozole trigger shot progesterone. This cycle, I didn't get a positive LH with testing, so I didn't do the trigger shot. I ended up getting a positive beta on day 29. On day 33, I went back and it was negative. I'm wondering if there's something that I did to cause the loss. No, there's nothing you did to cause the loss. I took a reactant, harmless. I had a friend tell me that it is not safe to take that. It's totally safe to take reactant. It's completely harmless in pregnancy. In fact, there are some immune protocols that actually put patients on reactant in order to improve their success rate. So you 100% are not at fault for anything you took, Jen. Don't worry about it. It was not the allergy meds. Also wondering if I should have started doing progesterone after the beta test on day 31. Yeah, I am a believer in progesterone, but I don't think it would have salvaged what happened for you here. It sounds like you had a chemical pregnancy. They are quite common. That's actually a good sign in some ways. It means it can happen for you. Keep on trying, dear, and you'll get there. Is it possible to never ovulate ever, even with meds? 2 clinics later and clear tubes, lots of follicles, nothing will get past 11 millimeters. No, that's not possible. If you take shots, you'll ovulate. Well, not ovulate, you'll grow, and then you have to take a trigger shot, and then you'll ovulate. There's no way you're not responding to shots. At least I've never seen that before. So give me a call and we'll see what we need to do. Our last failed IVF cycle had 3 embryos transferred. Wow. My partner's count was only 2 million. We did ICSI. Recently, his DNA frag test came back good. Does this mean previous issue is resolved? There is no way to know that. That's a good question, but it depends on what the issues were. Certainly, if the DNA fragmentation is good, that's good. Hopefully he no longer has a count of 2 million though, because if he still does, that means there's enough of a sperm problem that it could compromise the embryo development. So that's tough to answer, but a great question. You'd have to see the whole picture. What are my thoughts on using basal body temperature to track ovulation when trying naturally? I think you should abandon it immediately. I hate basal body temperature. It drives everybody, including the patient, the partner, and the doctor, absolutely nuts. And it's pretty much useless because loads of things can alter your basal body temperature. Just use an ovulation predictor kit, guys. It's so easy to do. Pee on a stick and you get your answer. Why would you sit there and graph and then yell, honey, I need you to come right now. My temperature's right. Like, it doesn't work that way. Just use the ovulation predictor kit. no stress, no problems. You got loads of time. It gives you a full day of warning. So no screaming, you're ready right this instant, come now. We have bucket loads of guys that get performance anxiety and then can't ejaculate because they're under the gun, so to speak, to do it. Abandon basal body temperature. It just drives you crazy. What are my thoughts on Plexus supplements? No clue. I have no idea what Plexus supplements are. Tell me what Plexus supplements are, Dev, and we'll figure it out. What is the estimated timeline from first consult until IVF considering COVID? 2 months if you wanted me to rush it, maybe 3 average. Well, not 3 average, 3 on the long side, 2 months if you wanted me to rush it. Less if you already have all your testing done before you come to see us because you went somewhere else. COVID isn't impacting anything anymore. And we won't be shutting down unless something disastrous happens. So you don't need to worry about that. I'm doing a good job, Doc. Thank you. I appreciate that. Are you seeing a higher rate of failed transfers during COVID now that might be correlated to high stress? No. So our last embryo transfer batch did extremely well. We had very high success rates. So I can't say that I am. However, I've been asked to check to see overall, like to do a presentation on whether COVID impacts fertility. Last week, not a scientific publication, but an Israeli doctor is claiming that COVID impacts male sperm. So I thought I'd go back and look at all the papers that are out there, but there really is not much on fertility. So we're not seeing anything at the moment. How many months does Q10 take to have its effectiveness? Well, they say somewhere around 6, but we usually are pretty happy after 3. So if you're taking CQ10, take it for a minimum of 3 months. 0.9 millimeter cyst was found on my last ultrasound. That's not a cyst, sweetie. If it's only 0.9 millimeters, it's a normal egg. Treatment prescribed was 3 weeks of oral estradiol. Then another ultrasound. Jenny from the block, that's a great title. You need to find a better fertility specialist. So if it was a normal black circle and it was 0.9 millimeters, that's not a cyst, that's an egg. I don't know why on earth they would tell you to go on estrogen for that. That's absurd. If you have a big, like a cyst by definition needs to be either filled with something, endometriosis, blood, a dermoid cyst, something like that, or it needs to be bigger than 3 centimeters. 0.9 is an egg. So yeah. Nicole on Facebook is asking if you're allowed to go to more than one fertility clinic. I'm not sure if you mean if I'm allowed to go or if you're allowed to go. You can go anywhere you want. I can go anywhere they'll take me. I currently have privileges at 2. Are endometrial polyps common post-labor? No. They're not common, but they happen. Do you recommend a specific brand of ovulation prediction sticks? Yes, whichever one is inexpensive because they're all the same. Nicole is asking, can you go to 2 fertility clinics at the same time? Yeah, you definitely can go to 2 fertility clinics at the same time, but I wouldn't recommend it because one of us is going to get annoyed at the fact that the other one is doing something different and we all do things differently. I wouldn't do that. So definitely don't do that. Nick, you live in Cambridge. That's awesome. Your best way to see me, just arrange a Zoom call and we'll do it via video. I do that all the time. So call my office, 519-944-6400. Leave a message. Don't hesitate to leave a message. Don't hang up because you get the phone treat. Leave a message. We will get back to you. Otherwise, you can email info@drvictory.com and request a consult, and we will get in touch with you. And I will be happy to help you out, Jen. Nicole, sorry. Plexus, probiotics and chromium/fiber mix. Probiotics are good. We use probiotics in our patients who are doing treatments for frozen embryo transfers. So yeah, I would use Plexus. Why not? And Nicole is emailing now. That's the way to do it, guys. If you're watching, you want to see me, just email. I'll be happy to see you. Would you take on a patient that has done gender selection in the US? Yes, although I can't help you with gender selection in Canada, but if you've done it before, I'll take you. It doesn't make a difference to us. Can high BMI lead to implantation failure? Absolutely. So if you go on our website, www.drvictory.com, you will, oh, they just set the alarm. That's a disaster. They have a whole section there under the resource guide that says obesity and infertility, and it lists all the complications that can occur when you have obesity or an elevated BMI as a problem. So that's definitely a, it's, you know your code, right? 1 second, guys. Just keep that company.
How's it going, everybody? I'm gonna keep you company while the doctor returns. My name's Tariq Ibrahim, and I'm the guy behind the scenes all the time, helping Dr. Victory answer all of your questions. So it's actually a two-man show most of the times, but you know, ultimately he's doing all the work. I just get him ready, and he's already back anyway.
Sorry about that, guys. Alarm went off. My apologies. So we got a few minutes left. Follow up. Yeah, there you go. Follow up with cyst found. My estradiol level was 590 on day 2 of cycle. Well, that's a different story. Although I'd actually repeat your estrogen level in a circumstance like that. Am I Dr. Victory's son? LOL, you look alike. Tariq is definitely not my son, more like my brother from another mother. He's a little mature, or I'm maybe a bit too young for Tariq to be my son. That is definitely one of the funniest things I've ever seen, though. Wow, there's a million questions on Facebook now.
That's why I showed up for sure.
Yeah. Hyalinized materials with calcification shown on hysteroscopy biopsy concerning? No, I've seen that a million times before. It's very common. Dev, you live in Alberta and you want a consult? No, you don't have to pay for an initial appointment. I'm trying to blaze through these questions now. What can I do to lower my blood pressure when I am 28 weeks pregnant? Low pressure is 140/90. You need to be on medication, Margaret, 100%. And avoid salt. Is probiotic okay during ovulation? 100%. It's actually good. I do not have an annual clinic fee. I hate places that do that. Just a comment, all these celebrity pregnancy announcements during COVID are so insensitive to the TTC community. I'm not saying they should not express their joy, but just to be sensitive with how they announce. You know what? If we could get celebrities to be sensitive about anything, the world would be a better place. Let me finish maybe one more question. If the Fertility test comes back with a positive result from a hidden C test, what treatment would occur? Antibiotics or antivirals? And maybe one more real quick. What is my opinion on immunological treatment, such as NK and IVIG? I think it has a place. It depends on your history. Okay, 8:59, guys. If you did not get your questions answered, send them to me via Instagram or Facebook or whatever, or email them to us, and I will happily get them back to you. We love you guys. Stay safe, and we will be back on again next week with another great show. Make sure you spread the word on tonight's show. I think it's a tremendous topic with a lot of really, really important value for all of you. There's always hope, so hang in there. We will get you through. Take care, guys. Have a good night.